Welcome to all of you to this really informative session on cardiac involvement in inflammatory arthritis. I'm Alessia Pepe. I'm a cardiologist and radiologist from the University of Padova. My co-moderator is Dr. Papanopoulos, a rheumatologist from Lakon Hospital in Athens. First of all, I would like to thank Sofia Mavrogeni for her huge work in pushing a multidisciplinary network and education in cardiac rheumatology. I'm really convinced that her work is giving a significant contribution in opening the prognosis of our rheumatic patients. Now, I'm moving to introduce the first speaker, Professor Nurmohamed. He is a professor of rheumatologist at the Amsterdam Rheumatology and Immunology Center. He will take a lecture on the rheumatologist's point of view in rheumatoid arthritis. Please, Professor Nurmohamed.
Thank you very much for this kind introduction. I will share my screen now. You see my slides?
Yes.
Great. Thank you very much. Once again, thanks for the invitation to discuss cardiac disease, cardiovascular disease in inflammatory arthritis, the rheumatologist's point of view in RA. My disclosures are shown on this slide. So what I will discuss today is the past and current epidemiological data of atherosclerotic cardiovascular disease in RA. What is then the effect of our anti-rheumatic drug therapies? And the focus will be on anti-TNF agents, and these agents are the most used biologic drugs in our daily practice today. And I will give a few words about cardiovascular risk management. So if we look at the causes of death in RA, then infections, lymphoproliferative disorders, and gastrointestinal diseases occur a little bit more in comparison to the general population. However, cardiovascular diseases, just as in the general populations, are the most important cause of death. But not only that, an RA patient has an up to twofold increased risk for cardiovascular atherosclerotic death. In the past, this led to decreased life expectancy of about 10 to 15 years. And one of the first comparative studies investigating this cardiovascular disease risk in RA was the CORE investigation from Amsterdam. In this prospective comparative studies, we investigated prevalent and incident cardiovascular disease underlying cardiovascular risk factors in RA patients who were aged at the beginning of the study between 50 and 75 years. And at the start of the study, these patients had a disease duration up to 12 years. We included 353 patients, started in 2001, and had a follow-up of 22 years. For comparison, we used participants of the HORN study. This is a general population cohort study investigating glucose metabolism, cardiovascular risk factors, and incidence cardiovascular disease in the general population. And this CORE investigation demonstrated a double prevalence of cardiovascular disease, a double incidence of cardiovascular disease, but not only that, it was comparable to type 2 diabetes, and at that time only partially about 30% explained by the cardiovascular risk factors like hypertension and dyslipidemia, making RA an independent cardiovascular risk factor. The 15 years follow-up data are shown on this slide, where the event-free survival is plotted against the time in years. The blue line represents the general population. The green line, patients with type 2 diabetes, and the red line, the patients with RA. And what you can clearly see is that from a cardiovascular point of view, patients with RA do it much worse than the general population. It was comparable at least to type 2 diabetes. We also published the 20 years follow-up data. And on this slide, on the left side, you see the hazard ratio, the cumulative hazard ratio for cardiovascular disease. Orange are the diabetes patients, blue the RA patients, green the control patients. And when you look at the unadjusted hazard ratio, then RA still has an increased cardiovascular risk in comparison to control. But if you adjust for the cardiovascular risk factor, and that's shown on the right side, then this increased risk in RA almost completely disappears when compared to the general population. In other words, nowadays, increased cardiovascular risk seems to be attributed mainly to the cardiovascular risk factors. Well, you could say to, well, Mike, the CORACE study was started more than 25 years ago. How's that with contemporary patients? Well, Professor Gert-Jan Wolmink and colleagues investigated and demonstrated in patients with rheumatic diseases that they adhere more to COVID-19 isolation measures more strictly than the general population. But they also looked at cardiovascular disease, and you can find that in a supplementary appendix. And they found that when comparing almost 1,000 patients with RA, in comparison to 400 controls, they still had a substantially increased cardiovascular risk. So nowadays, there's about 50 to 60% increased cardiovascular disease risk. Okay, what's then the contribution of cardiovascular risk factors versus the disease activity characteristics in their contribution to cardiovascular disease? Well, let me take you to this ETHIC RA study. This study comprised 5,600 patients from 13 cohorts from 10 countries. There was a 6-year follow-up, during which period there were almost 400 cardiovascular disease events. And these investigators demonstrated both inflammation and inflammatory markers contributed. But when looking at the PARS, then only 30% of the increased cardiovascular risk was due to RA characteristic, and the majority was due to the traditional cardiovascular risk factors. So today, cardiovascular risk factors contribute more towards the cardiovascular risk in RA than 25 years ago. So how can we then explain the relation between atherosclerosis, increased atherosclerosis, and rheumatoid arthritis? Well, if you look at the pathogenesis of RA and atherosclerosis, there are many shared inflammatory pathways. So IL-6, IL-6, I1, IL-6, TNF, and the downstream JAK signaling contribute both to atherosclerosis and RA. And for instance, the IL-6 and IL-7 lead to plaque destabilization and thrombus formation on one hand, and on the other hand, to bone erosions. And if you target these pathways, you could expect a decrease of RA disease characteristics as well as the atherosclerosis. If we look at the interaction between cardiovascular risk factors and inflammatory risk factors, then increased disease activity in RA is associated with pro-inflammatory cytokine production. This leads gives quantitative and qualitative lipid modification and increased cell formation, post-translation modification and autoantibodies formation give more oxidative stress and endothelial dysfunctions. And these RA-related factors interact with traditional cardiovascular risk factors such as diabetes, smoking, hypertension, obesity, genetics, and chronic kidney disease, amplifying the cardiovascular risk in RA. If you look at the acute myocardial infarction, that's mostly due to plaque rupture followed by superimposed coronary thrombosis. This occurs frequently on non-obstructive coronary plaque, the so-called vulnerable plaque, and has characteristics of less than 50% luminal narrowing. And when you compare stable plaques versus unstable plaques, then a stable plaque has a lipid core ratio of less than 50% versus more than 50% in vulnerable plaques, and the fibrous plaques of more than 100 micron versus less than 100 micron. If we look at coronary calcification and plaque vulnerability, then the high calcium content means a low probability of plaque ruptures. So these are the so-called stable plaques, and low or no calcium content means a high probability of ruptures, the so-called unstable plaques, as shown on this slide of this insert. So this study compared coronary plaque formation in 150 RA patients versus 150 controls. They used 65-4 slice CT angiography and looked at the number and composition of plaques, and lesions were characterized by non-calcified plaques, mixed plaques, and fully calcified plaques. And overall, patients with RA had 70% plaques, they had more plaques, more extensive plaques, and more vulnerable plaques, and also more segments with plaque in comparison to controls from the general population, and also more extensive peripheral disease. So patients with RA have a higher prevalence, extent, and severity of all types of coronary plaque, and an increased disease activity. It's called a DES-28 score of more than 3.2, and a DES-28 score is a composite measure comprising the number of painful joints, the number of swollen joint, an acute phase reaction, either CRP or ESR, and patient global. And this was associated with a higher risk for non-calcified plaques or mixed plaques, increasing the risk for adverse cardiac events. So targeting disease activity might perhaps decrease the risk for future cardiovascular events. That's the question. And in this pilot study, we looked at arterial vessel wall inflammation with PET-CT scanning in 29 patients with active disease activity, RA patients, versus 11 osteoarthritis, OA patients. We looked at standardized uptake values and found that focal and total arterial uptake was higher in RA patients versus osteoarthritis patients. And within RA, there was a correlation with CRP and a higher disease activity score. And the next question, of course, what happens then with treatment? Here, a representative patient from the previous mentioned study. You see here the uptake at baseline, and after 6 months methotrexate treatment, and that's one of our conventional treatment for RA, there was a clear significant decrease of the SUV max of the carotids, and also a clear decrease of the disease activity. And the next question is, of course, how does this decrease of inflammation, does this also lead to a decrease in cardiovascular clinically adverse event? Well, we still do not have direct comparative studies, But valuable information comes from this database study where it's a US insurance database study where we investigated 440,000 patients with RA were treated with anti-TNF versus 47,000 patients who were treated with methotrexate versus 26 other treated patients. And you can see the total number of patients years and the cardiovascular event rates uh, during 100 patient years of exposure. And what we saw is that after 6 months of TNF exposure, these patients had 12% less cardiovascular events than those treated with methotrexate or other biological DMARDs, whereas steroids led to an increase of 6% cardiovascular events. In general practice, we treat patients for several years, and the risk reduction that we saw of 12% would mean that after 3 years of treatment, this would lead to a 51% reduction at 3 years. If you look at other cardiovascular disease, cardiac diseases in RA, then this study was published 3 years ago, investigating autoimmune disease and cardiovascular risk in 19 autoimmune diseases and 12 cardiovascular diseases in 22 million individuals in the UK. And overall, patients with RA had about an 80% risk of all kinds of cardiac and cardiovascular disease in comparison to the general population. And rheumatoid arthritis comprised the largest population of connective tissue diseases in these investigations. And they found a 70% increased risk of heart failure, and that was a topic that I discussed last year. About 50 to 70% increased risk of arrhythmias, and similarly, aortic aneurysm, myocarditis, and pericarditis were also observed more in comparison than in the general population. So, the excess cardiovascular risk in RA is explained by cardiovascular risk factor as well as the chronic inflammatory process. We nowadays know that atherosclerosis is an inflammatory disease. RA is an inflammatory disease, so the inflammatory process in RA leads to an accelerated atherosclerosis development, and therefore RA should be considered a relatively new independent cardiovascular risk factor for which cardiovascular risk management is necessary. And how is that done? Well, you all know you start with assessment of blood pressure, lipid profile, glucose, etc. And then you use a score, such as framing or score risk calculation, to assess the 10 years fatal, non-fatal cardiovascular disease risk in RA. And nowadays in Europe, we use the score 2 and score 2 for older persons. And on the basis of age, sex, smoking, yes, no, systolic blood pressure, non-HDL cholesterol, you calculate one's risk. And the recommendations are then as follows. Everybody should get lifestyle recommendations that account for the whole population, and treatment with antihypertensives and or statins is only necessary when the 10 years cardiovascular disease risk is high. So if we look at this table, this is in Dutch, but the table itself can be understood. So suppose we have this 60-year-old man who smokes. Then his 10 years risk for fatal and non-fatal cardiovascular disease is more than 10%. So this would indicate treatment with antihypertensives and or statins. But suppose he does not smoke, then treatment might be necessary on the basis of other risk factors. But if this man was a woman, then no treatment with antihypertensive drugs and or cholesterol lipid lowering agents is necessary. And for RA, these tables, these risk scores, are in that case a multiplier of 1.5 is used to get a more approximate estimation of the cardiovascular disease risk in RA. So that's a theory. How is cardiovascular risk management actually done in RA? And let me take you to this implementation study where we studied at baseline 720 patients. The yellow uh, bar color indicates no treatment indication. The green bar indicates no treatment indication. The yellow bar, the adequately treated patients. The brown bars, treatment goal not reached. The red bar, treatment indication and not treated. And at baseline, almost 69% had an indication for treatment with statins and or antihypertensives, but only 40% or so were adequately treated. We sent a letter to the general physicians to improve this, but 1 year later, this hardly didn't change. So that's very worrisome. And this is not unique for Amsterdam. If you look at this nice editorial, then it states that some practices are screening for cardiovascular disease risk factors, ranging from intensive individual screening to brief clinic rooming practices that connect patients to primary care, or quit lines to address risk factors. Other rheumatologists debate ownership or lack implementation support so that the CVD prevention gaps remain unaddressed. So, the cardiovascular disease risk is increased. The increased risk, the events occur 1 decade earlier than in the general population. This leads to a decreased life expectancy in RA. In the past, it was 10 to 15 years shortened. Currently, it's about 1 to 3 years shortened. The major cause is inflammation leading to accelerated atherosclerosis, making RA an independent risk factor for cardiovascular disease. But also traditional cardiovascular risk factors are important. In the past, it led to a decreased. In the past, they were responsible for 30% of the increased risk. Presently, they're much more important, and the risk is now 70%. Effective anti-rheumatic treatment therapy reduces the cardiovascular disease risk in RA. Methotrexate did not have effect in the general population, probably because it didn't attack the inflammation pathway, as anti-IL-1 agents like colchicine are effective in secondary cardiovascular disease prevention. And with respect to colchicine, this might also work for primary CVD prevention in selected RA patients with a high risk of cardiovascular disease, and an adequate trial in this area is urgently needed. Conversely, stopping tapering anti-rheumatic treatment might increase cardiovascular disease risk, but this topic needs further investigation. So, RA is an independent cardiovascular risk factor. Proper cardiovascular risk management implementation is urgently needed. Rheumatologists should know that even nowadays the increased risk is still increased. And perhaps the update of the EULAR 2026 recommendation for cardiovascular risk management in patients with rheumatic and musculoskeletal diseases will facilitate this process. Heart failure is a silent killer. Perhaps screen earlier didn't talk about that today. But altogether, I feel that a multidisciplinary approach is necessary where rheumatologists, cardiologists, and primary care physicians are working together to decrease the cardiovascular burden for our patients. Thank you for your attention.
Thank you, Professor Nurmohamed. Excellent lecture. Are there questions from the audience? No, nothing in the chat. I would like, I have a question for you. We are all agreed that RA is an independent cardiovascular risk factors. Based on the last guidelines, European guidelines, all patients with a probability of coronary artery disease more than 5% as an indication to a core CT. Which is, if we consider RA an independent risk factor, all patients with RA as indication to core CT. And this technique could be useful to recalculate the risk of our patients and the target for statins, for example, because if I have a plaque also less than 50%, I have to improve my therapy with statins, which is your experience, your opinion. Last guidelines are really recent, a few months ago, and so we have discussed all together the indication.
Yes, it's a very important question. In the Netherlands, when it's available, then we use it. Then it reclassifies patients to a higher cardiovascular disease risk, but we do not recommend to do it standard in our patients. And the reason for that is also for practical purposes, because we don't have the capacity to screen all our patients with coronary angiography. But that's an important topic, and I don't know in which direction it will go the coming years. And that's what we are now developing the new recommendation in this respect. So hopefully that will give some more insights.
Thanks for your comment. I suggest to push the indication and don't stop because we don't have a viability.
Yes.
For example, I remember the history about CMRI and sclerodermia. 15 years ago, we said we cannot say one MRI for all patients because we don't have a viability. Today, in our European recommendation, we say an MRI for all patients when we have a new diagnosis. So I think we have to work in order to give this exam to our patients and perhaps to identify at which age.
Yeah, but so this will be a very important topic. So we are currently developing a new recommendations, and this will be a very important topic. Hopefully, we get consensus in the new guidelines, and hopefully, I think the first manuscript will be published end of next year.
Thanks for your comment. Okay, we don't have questions from the audience, so I left the words to my co-chair.
Okay, thank you.